Good morning, everyone. Lovely to feel all of the energy in the room and be in a collective space together. Thank you for all being so prompt and joining us nice and early. My name's Dan Shaw. I'm the District Nurse Manager for Patient Experience and very fortunate enough to be here as one of the two MCs for today. I work very closely with Lucy, who most of you will know, supporting falls prevention and management across the district, a topic that's very close to our hearts. And we're so pleased to see all of you here today to share in a day of learning, ideas, and conversations and creating new networks. So I'll hand you over to Jane, who will introduce herself.
Thank you, Dan. There's been great debate about which type of microphone to use this morning. We might just do a sound check for people online. Are people hearing us? Fantastic. Brilliant. So we're attempting a hybrid model today, so we'll see how we go with that during the day. So hi everybody, my name is Jane Trelog and I am the Clinical Stream Manager for Aged Care and Rehab. I'm relatively new to this role. I've been involved in the district within organ and tissue donation, so aged care and rehab is very different specialty, but loving it. So we really look forward to having you all contribute today. There'll be various ways of contributing during the day with the Slido and with asking questions. And for those of people online as well, we'll probably have about the same number of people online as we have in the room. So there's a fantastic registration and attendance. Dan, there was something else I was supposed to mention. Okay, then we'll
covered it all beautifully. Thanks, Jane. So it's great to have you all here, and what I'd love for you to do is just give a shout out to those people online. They can see you, but it'd be really lovely to hear you. So if you just give them a big good morning or welcome, that'd be great. Oh, we can do better than that. Come on, 1, 2, 3. There we go. Beautiful. Wonderful. Well, great to have everyone here in those multiple mediums. So just a little bit of housekeeping to get us started. If we do hear the fire alarm tone, you can follow myself or Jane up the auditorium stairs, out the front door to South Street, where we'll head up towards the hospital, right onto Belgrave Street, and our assembly area is outside the hydrotherapy pool. So you can follow us to that point. Morning tea and lunch will be held in the function room today, which is right next door where you registered, and we have the seminar rooms opposite for those of you who want a bit more space to break out and not be cramped in one room, and also to help us adhere with those COVID safety rules. So for today, we've capped attendance in the audience at our COVID safe number to allow us to freely be here without the imposition of masks. However, we do have them available for you if you choose to wear them, and you are welcome to do so. They're available at the registration desk, the front entrance. We also have plenty of hand sanitizer, and just being mindful today as we interact with each other that we're socially distancing. There's plenty of room here in the auditorium for us. Probably not a problem for those of you online, but if you are gathering in a room, just be mindful. In the registration room, we have a number of different representatives here for you to connect with. We have Keystone Healthcare, who have kindly provided lunch for us for today, which is really wonderful. So round of applause for Keystone. And we have our delirium and dementia CNCs who are talking a little bit to you around what they do and promoting World Delirium Awareness Day, which is later this month in March. We have COTA, who are here to share a bit about the programs that they run and the work that they do. And we also have our MedApp team, who will be here to talk to you a little bit about their IT solution and how we're using that across the LHD to support various bodies of work, from new grad orientation right through to quality improvement initiatives around falls. So as we move throughout today, as Jane mentioned, there's plenty of opportunity to interact, share, post questions and queries. You may notice in the registration room there are some orange posters up with some colourful trees. They're also in the seminar room. And as we move throughout today, we really want to encourage you to share your curiosities, some questions that you might have, your reflections on today, and any ideas or inspirations that you go away with that are mulling around in your mind throughout the day. So those opportunities are in both of those rooms to pop those post-it notes up and share those with us. So I'm going to hand over to Jane, who's going to do our welcome to country.
Thank you, Dan.
Wow.
Acknowledgement of country,
Sorry.
yes. No. So we acknowledge the tradition. Oh, I knew I would stumble. My apologies. We acknowledge the traditional custodians on the lands in which we stand and those whose lands our facilities are located on. The lands of the Darrawal, Gadigal, Wodjigal. I knew I would get this wrong. My apologies again as well. Gadigal, Wongal, Garrawal and Bidjigal peoples. We pay our respects to the elders past, present and those of the future. And we also recognise and appreciate our consumers, our patients, the carers, the supporters and their loved ones, the voices of the people with lived experience that are powerful. Their contribution is vital to enabling decision-making for health system change and is the reason we're here today. So I'd now like to invite Mr. Tobi Wilson to come and open our proceedings on our inaugural Falls in Focus Forum. Lots of Fs.
Thanks, Jane. And thanks, Dan. Thanks, everyone, for inviting me along today. Can I also start by acknowledging the traditional custodians of the lands on which we gather, Bidjigal and Gweagal people here, and the traditional custodians across our district and beyond, for those that are joining online. It's great to be here today. Obviously, a really important topic, and I'm really excited about what hopefully will come out of today. It's going to be a very interactive day, I'm told, and there's going to be plenty of opportunity for people to engage and share ideas and get exposed to what is some of the latest research that's coming through, updates on coming out of the CEC, some of the work that's also coming out of the New South Wales Falls and Healthy Ageing Network, be exposed to new technologies and innovations, comprehensive care management and falls prevention. Dan and Jane have also got a little bit confused around April Fool's Day jokes, and we're now opening or starting to talk about what April Fool's Day would look like on the 1st of March, which I think is a trick on me, which made me read the briefing notes a few times to get my head around what's going on. But I understand there'll be discussions around what is going to happen for April Fool's month and how people can be engaged. And obviously that's a really important event across the district because it gives us a chance to really talk to the entire workforce about the role that they can play in falls reduction, falls prevention, and really profiling the importance of the strategies that we can take when people are with us within our facilities, but also the interventions that we can make for people that are interacting with us and how we can support them in the community to put in place strategies that hopefully prevent them from falling in the first place. I'm sure I'm going to tell you stuff you already know, but falls are obviously a big issue within healthcare at the moment, and it's only going to get bigger as we continue to see an ageing population. So there's estimates of around $2.3 billion cost to the Australian healthcare system from falls every year. And we obviously know how devastating falls are for the individual and for the loved one, and particularly the morbidity that's associated with falls. So many people that come in and fall, particularly if they fracture something when they fall, they will never regain their full function. And that long-term benefit, a long-term deficit that can cause is obviously considerable. We also know that COVID has been a particularly challenging time for a number of people, and we're seeing the impacts of that coming through in the people that are presenting to hospitals, condition that they are presenting in, so which puts them more at risk of falls. So unfortunately, for a number of people that are at risk of falls, they have had the last couple of years been particularly tough. It's led to more social isolation than maybe what they were experiencing before, less physical exercise, more deconditioning, and therefore more risk of falls. And as a result, we need to be more focused on the interventions that we can make in that space. Falls are obviously really important in terms of where they sit within our strategy from a district perspective around providing patient-centred care, really around focusing on safe, integrated, accessible and evidence-based care that places people at the centre. And I know that's going to be a strong theme that's going to come through in many of the discussions today. But I also really want to call out the importance of partnering for healthier communities and the role that we can all play in that preventative space and having those conversations with people that we identify as at high risk of falls around what we can do in the community, how we partner with people outside our organisations, so not-for-profit, local councils, all of those groups that have got programs that are all around social inclusiveness, around exercise, around encouraging people to engage, which we know will reduce the risk factors associated with falls. And again, our role that we play in that space of introducing people to these programs, having those incidental conversations, taking the opportunity to raise these things with people, and really pointing them in the direction. And again, my particular call out, as you will hear me go on about constantly, is about particularly for those that are most vulnerable in our community. Where are we having those conversations? How do we intervene in those groups? We know that if you're coming from a low socioeconomic background, if you're coming from a culturally or linguistically diverse background, if you're Aboriginal, identify as Aboriginal, you are going to have you're exposed to worse health outcomes, and that includes falls. So those conversations, those opportunistic conversations we can have to intervene before somebody falls, is obviously really important for us to be able to do. So on that note, I'm going to get out of the way because there's a lot more people to speak to you that know a lot more about this topic than I do. But I look forward to seeing the outcomes of the day, and look forward to joining hopefully many of you in the celebrations that we will have through April Falls Month, and really highlighting what is a really important topic for us to be talking about. So thank you, Dan.
Thank you, Toby. Really wonderful to have you here today, and your executive support around falls, and really setting the scene for us and talking to us about our responsibilities as part of that. So I'm going to introduce our next speaker this morning, and I'm going to welcome Lucy Haver, who's our Falls Prevention and Management Coordinator, to share with us this morning a little bit about keeping older people safe. So Lucy is, as I mentioned, our District Falls Prevention and Management Coordinator, and is an occupational therapist with 20 years experience predominantly in aged care and rehab in the community, inpatient and RACF facilities in Australia and the UK, with a keen interest in falls prevention and frailty. Wonderful career experience there, Lucy. A little fun fact, we've asked all of our presenters to share a fun fact today. For those who haven't, we might put you on the spot, an interpretive dance perhaps. Lucy spent her birthday lunch last year with joint birthday celebrations with Chris Hemsworth and Matt Damon. It's very exciting. Welcome, Lucy. And just before we kick into Lucy's presentation, we wanted to share an opportunity for you to interact with us today. For those online, we are using Slido to take your comments and questions. You've also got the chat function, and we have the wonderful Ali who's looking after that for us today. Thank you, Ali. So those of you in the room, take note of the number on the screen. Get your phones out, scan the QR code. For those of you who can't scan the QR code from where you're seated, you can go to slido.com and enter that number in, and you can use that throughout the day to pose questions, curiosities, ideas as we move throughout today. We will attempt to get to questions for our speakers, but we do have a fairly jam-packed day, so we can take some of those away and share some FAQs with you after today's event. So I'll hand over to Lucy, who's going to share with us keeping older people safe. Thank you, Lucy.
Thank you, Dan. Yes, I'm Lucy Haver. Good morning, everyone, and I'm the SESLHD Falls Prevention and Management Coordinator. And today I'm talking about keeping older people safe. The falls remains the leading cause of injury hospitalisation in Australia. In South East Sydney, falls is the second most reported incident behind concerning behaviour. In the last 3 years, there has been an increase in falls incidents each year, and concerningly, incidents resulting in major harm or death in our facilities following a fall or a hack fall. This graph shows the hack falls or major harm from falls from 2020 to 2022. Peaks in hack falls were seen in August 2021, January to February, April and August 2022. COVID management, winter and staffing pressures are some of the significant contributing factors. This graph shows the hack falls of all the LHDs in New South Wales from 2020 to 2022. Of the 17 LHDs in New South Wales, SESLHD is in the lower fifth on average over this time period with a rate of 4.7. SESLHD's target rate is below 6.4, and in 2022, a challenging year in healthcare, our rate was 5.9. And I think that's something to be commended in such a challenging year. This graph shows the IMS plus rates from September, when IMS started 2020, to December 2022, and this is the falls count. The navy blue line on the top is New South Wales, and the light blue line on the bottom is South East Sydney. On average, SESLHD reported 275 falls incidents every month. There was a significant increase in the number of incidents reported from February to August 2022, and the New South Wales state replicated a similar theme. This graph shows the New South Wales and SESLHD falls rate from IMS Plus from September 2020 to December 2022. SESLHD's falls incidence rates have sat above the New South Wales most of this time period. But like the falls count, SESLHD's falls rate followed a similar trend. Falls are often an outcome of other areas of clinical management that may need further review and focus, such as toileting and urinary tract infection management, early mobilisation, pain management, orthostatic hypertension, delirium management, hydration and nutrition, polypharmacy, and effective communication of risk. With a growing older population with complex comorbidities, it is important to identify individual patients' risk factors early. These need to be mitigated. Those individual risk factors need to be mitigated with evidence-based strategies from a comprehensive care perspective. In November 2022, a new report at Neura was launched on why investing in falls prevention can't wait. This campaign by world-leading falls researchers and clinicians proposed a plan for urgent and coordinated action that could reduce falls by 30%. I'll now show you two videos from the launch, one by Professor Kim Delbert and Professor Kathy Sherrington introducing the launch, and the second a video by Bob Barnes, who presents his personal experience with falls. We thank Bob and his family for kindly giving us permission today to share his story with you all.
So I call Professor Kim Delbert, who's the Senior Principal Research Scientist at Neura and President of the Australian New Zealand Falls Prevention Society, and Professor Kathy Sherrington, who's leader of the Physical Activity, Ageing and Disability stream at the Institute of Musculoskeletal Health, who are going to update us on the report and tell us why we need to act now. Thanks, Kathy. Thanks.
Thank you, Jane, and thanks everyone for coming today and supporting us in this important cause. It's really heartwarming to see you all online as well, and we definitely hope that we can create something here and make a change. So we're here today because we really want to call on the government and make it very clear why we can't wait to invest in falls prevention across Australia. Falls prevention is an important problem. Falls is an important problem in older people, and we have an ageing population. Now we have 4 million Australians aged 65 and older, and in 20 years that will be 6 million older Australians. And injuries as a result of falls, they are a growing problem. And as you can see on this graph, falls is absolutely by far the leading cause for injury-related hospitalizations. Like, it's stunning, isn't it, to see this graph, how big that difference is if you compare it to, for example, transport accidents and others that are on there. This is for the entire Australian population, but if we think about older people, they are absolutely making up the largest proportions of these numbers. We had, in 2020, we had 130,000 older Australians being admitted to hospital because of a fall. In 20 years, that will be over 200,000. We had 5,000 people dying as a result of a fall, and that will increase to 8,000. And if we think about what will happen today, there will be 364 older Australians being admitted because of hospital. It is because of a fall. It is a huge problem. And we really call for action because it is urgently needed to do something. The treatment of injuries from falls in last year came at a price tag of 2.3 billion. This is just a price tag in our older Australians aged 65 and above. And there are lots of flow-on effects as well for ambulance services, people attending ED. If we think about today, again, like every 2 minutes and 30 seconds, there is a person that attends an emergency department because of a fall. There's 1.2 million fall-related patient care days needed for people aged 65 and above. And if we think about the other aspect, like we're just talking about cost, but there is so much more as an individual cost as well to the person. If you have been admitted because of a fall to hospital, the chance that you will lose your independence is twice as likely. So there is a cost on so many levels that we very much would like to address and make sure that there is an awareness in the community to drive change. Australia doesn't have a national falls prevention strategy. We used to have one, but it lapsed in 2014. And now we are calling for coordinated action because as falls researchers, we know what to do. We know what can change this. And we know that it can actually reduce this cost by 30% with a quick turnaround, like within 12 months. And if we come up with a well-implemented falls prevention strategies, we will have long-term benefits for other aspects of health as well, quality of life and independence of our older Australians. Kathy will talk more about the evidence of what type of things we can do to prevent falls. But what we know is that for people with specific fall risk, we can have targeted interventions. But the single most effective strategy to prevent falls, and that is what Kathy will talk about, is exercise. And that is across all older people within the community, within residential aged care. So it's time to absolutely take action on this and to practice our balance. Should have done this on one leg. Thank you. I'll hand over to Kathy now.
Thank you, everyone. And yeah, what a delight to be here with you today. And as Peter said, I've been associated with Neura for a long time, having done my PhD here with Stephen Lord quite a few years ago. So fantastic to have so many people with us today in person and online, helping us to get this issue on the agenda. So we're going to So this has been announced recently. This is an algorithm from the World Falls Guidelines. And these are evidence-based guidelines that have been put together and have just been launched in the last month or so. And this involved 100 world leaders in falls prevention, and quite a few Australians were involved in this as well. The Australians are shown there in orange. And I think this is a really nice summary of the evidence and really helps us think about the different strategies that we need. So it's a bit busy, but just to highlight here, so this algorithm talks about falls prevention for everybody. So it talks about low risk people where we're talking about primary prevention. And that's where the information from the fabulous Herald article this morning from Jenna Price about the need for even younger and middle-aged people to be doing exercise that challenges balance, so such as by standing on one leg. And so we need really those sort of cultural awareness and messages about the importance of exercises that challenge balance and strength. And then for these intermediate risk people, people who are at some increased risk of falls, we really need to be able to deliver tailored exercises with input from health professionals such as physiotherapists and exercise physiologists. And then for these higher risk people, the recommendation is for a multifactorial falls risk assessment to address those other risk factors that we also have evidence for that have a role in preventing falls. And so to me, this is a really useful summary of the evidence and can guide further action. I'm going to tell you a little bit more about some of the other evidence. So this was from the Cochrane review that we did, where we were able to, using very rigorous techniques, we were able to conclude that there was high certainty evidence that exercise can prevent falls. And Cochrane reviews these days get us to turn the result into the number of people affected. And so if we were to follow 1,000 older people for a year without exercise, there would be 850 falls. But with the type of exercise programs that were in the report, there would actually be 195 fewer falls. So really the potential is enormous. Falls now are in the World Physical Activity Guidelines, so as part of this type of evidence, guided by this type of evidence. And so they actually talk about the need for exercise that challenges balance and strength to enhance functional capacity and prevent falls. The World Health Organization also gives us the really useful global action plan on how to enhance physical activity, which I think is also really relevant for falls prevention. So we need to be considering our environments, we need to be considering our systems, our funding and support systems. We need to consider societies and social norms and be promoting this type of exercise and making it normal. And we need to be supporting people to be active with programs and services. So we're just going to hear.
And so we've got Bob, who's joined us all the way from Lismore. His Sunday profile on the Lismore app describes him as a business legend, a family man, a committed volunteer, a celebrated Rotarian, and he's currently president of the Rotary Lismore West, and an inspirational individual. So it's such a pleasure to meet you, Bob, and to invite you to tell us about the community experiences you've had with falls and about some of the impacts that falls have had on your family. Thanks very much.
Thank you. Good morning. My name is Bob Barnes, and I'm a typical Aussie. I've lived in Lismore all my life, played sport, run businesses, have a big family, been involved in a lot of community activities. I'm president of the local Rotary Club. I'm 83. I've come to speak today on behalf of the 4 million Aussies aged 65 and over. I'm going to tell you about my friends and loved ones, but they could just as easily be your friends and loved ones. And I want to help give a message to Australia. My wife and I have wonderful friends, Pam and Ian, who live on a small farm just out of town. Pam was a great hostess. She was into everything and knew everyone. But one night in hospital, not long after surgery, Pam had a fall. Things went downhill quickly after that, and she ended up in care. This is our friend Pam and her husband Ian today. After the fall, Pam never went back to the farm. It burdens me to tell you that my own dear wife, Helen, became a falls risk. She developed shingles in her eye last February. It really knocked her around, and she's still in constant pain. She was on heavy medication and had a couple of busters. But after one of her falls, the ambulance was called. It's unsettling to be in your pajamas at 3 a.m. with paramedics in your bedroom. Now, I'm not an educated man, but I do know falls don't discriminate. And the family soon realised that a tumble could be the beginning of the end. I tried tying a cord from her wrist to my wrist when we went to bed so that I'd know if she was getting up. A gate was installed at the top of the stairs. A couple of the kids moved back home and we watched her like a hawk. Things were rough, but we soldiered on and got into falls prevention mode. Trip hazards were removed. We got some night lights. We cleaned up her medication, fine-tuned her diet, and she has physio regularly. Here's a couple of photos taken of Helen recently. As you know, it's easier to put a fence at the top of the cliff than an ambulance at the bottom. So with friends from Rotary in Lismore and Balna, we started an information drive about falls prevention. We learnt that 14 Aussies aged 65 and over die from a fall every day. Out of curiosity, we also added up how many Aussies die daily from car accidents, cycling, drowning, death by suicide, and melanoma combined. It came to 16 in total, just 2 more than falls. When I tell this to people, they're absolutely amazed. Every year, falls cost the country billions and have a huge domino effect on families and the community. You've heard about click-clack front and back. You've seen drink driving and road safety ads on TV. You've heard about drowning prevention from Laurie Lawrence. You've heard the Black Dog Lifeline. And you've also heard about slip, slop, slap. But until our friend Pam fell and didn't go home, I hadn't heard or even thought about falls. It's obvious that falls are a very significant issue, but they don't get significant attention. I said that I'm here today to speak on behalf of the older generations of Aussies and to help get a message to Australia. Well, as older Australians, we would love to see a big wake up about falls prevention. Helen's fall story is a good story, but sadly, Pam's story is not. Everyone in the country should ask themselves, what will the story be for them and their loved ones? Falls prevention should be in the national consciousness as much as slip, slop, slap, and we should shout it from the rooftops. From Burke to Bullamakanka, from loved ones to loved one, from government to government, until, as a nation, we do something about it.
Thank you, Lucy. Wow, what a call to action. Are there any questions for Lucy? You have a couple of minutes to ask a question. Lucy, do you want to jump back up on the mic?
Hi, Lucy. My name is Lisa Woodland. I'm the Director of Health Equity, Promotion and Prevention for the district. What's the equivalent of slip, slop, slap for falls prevention? What would you like to see in the media, on the buses, you know, on our signs?
Yes, sorry. Libby here? Hi, Libby. Yes. About having certain exercises. Sorry, you might be. Can you hear me now? About certain exercises that are the key exercises for people to use, just so they're kind of inbuilt in their head in regards to, I think we were saying 3 to 5 main exercises that people know and can use at home to prevent falls prevention.
Any other questions for Lucy? I think the challenge today is for all the presenters to stand on one leg. The entire presentation. Okay, we will move on then. So Dan is just fixing up our camera situation for those online. Have we fixed the situation?
I think we have.
Brilliant.
Yes.
Fantastic. So I would now like to introduce Lorraine. Would you like to come forward, Lorraine? What's the microphone? We have a variety.
I've got a clicker. Right. Excellent, thank you.
Oh, thank you. Too many microphones. Our fun fact for Lorraine is that you got to sit at the day 3. Thank you. Thanks, Dan. You got to sit at day 3 of the SESLHD test on the pink day, and you got to watch the rainfall all day. Unfortunately.
Following on from that story, we did sit and watch all day, and then my brother, I come from a cricket tragic family, married to a cricket tragic, and we sat there all day. And then my brother said to me as we were walking out to go to the pub for a drink, we thought it was worthwhile, and about 4 o'clock, he said, I don't get you people, how you can sit here all day when there's no cricket and watch the rain. What it was we're catching up with old friends, we were talking and collaborating. And I guess that's the theme around what we're trying to do now, is how we build collaboration together and work together. Slightly different socially, but it's really important how we can all get together and begin to share and work together how we're going to resolve and work improving care for older people. I just want to touch on the demographics, which we've started to hear, and I know this is a busy slide, but if you're really interested, you can go to the New South Wales Future Health Plan, guiding the next decade of care for New South Wales, 22 to 32. Importantly in that, today people over 65 account for approximately 35% of the activity in the health system. And we also know that people aged over 65 with comorbidities and geriatric syndromes, which include pressure injury, falls, delirium and urinary incontinence, have longer and more resource-intensive stays in hospital, and prevalence increases with age. So it's really something for us to be mindful about, especially those of us who are working in our acute settings and rehab settings as well, and you'd be very mindful of that. That's what the strategic framework looks like. And I'd like to highlight that there is actually a particular strategy around people are healthy and well. Investment is made in keeping people healthy to prevent ill health and tackle health inequality in our communities. I was really encouraged to hear from Tobi talking about prevention and how we can start looking at what we need to do in terms of community interventions into the longer term. We did have a plan in New South Wales around falls, and it was involved in how we worked in community, how we worked in health promotion, and more effectively with researchers as well. Building on from what Lucy's introduced in terms of the National Call for Action, the follow-on from that call for action was, our question is, what are the implications for New South Wales? So we know that in that National Call for Action that the data that they've presented is Australian-wide data, national data. So now we're working with the Ministry of Health to look at specifically what the implications and the data looks like for New South Wales, what that burden is for fall and fall-related injury affecting our hospitalisations. So we're having a roundtable in early April. We've called and sent out invitations to key people across the Ministry of Health. This is a starting point. We will be presenting the New South Wales data prior to that. We are liaising with Bob Bob is our champion consumer. I mean, you couldn't get anyone better who's put it into a framework and the effect of the trauma. And I was talking to his son recently, and he said, yes, we keep thinking about the slogans and what we can say. And he said, my sister came up with, a fall can cost more than a trip overseas. Now, that's very true in terms of you've got trauma and all the implications of trauma and so on. But we want positive messages as well. So any great ideas and thinkers out there that can come up with a slip-slop type campaign for us would be most grateful. I'm going to talk to you a little bit about the CEC and the work that I do from the CEC. I did start with the Falls program, and we've evolved into the Older Persons Patient Safety program now. But I just thought I'd just give you an overview of the CEC and our strategic plan in terms of the work we're doing, and more particularly around our safety culture and accountability, and what does that mean for us as well. In our Older Persons Patient Safety program, we have some priorities around how we're focusing our work. Leadership, culture and accountability, building a culture of safety. Now, when we talk about leadership, we're not talking about necessarily, we're talking about it, from all perspectives. Each one of us is a leader. Each one of us can lead. Each one of us can be involved in driving change. It's a matter of how we support one another collaboratively, acknowledge that, and how everyone, frontline staff, feel comfortable in raising an issue if they feel where there's an opportunity to drive improvement in care. We're talking about partnering. We partner across LHDs, so we work across New South Wales with all of our LHDs. I work closely with Lucy and the team of Falls coordinators, but also I liaise with the Dementia Care CNC groups, ACI through the Aged Health Network, the Musculoskeletal Network, all those other areas, the frailty team at ACI, beginning to look at all that broader issues in regards to the safe care of older people. And we're also working to build capability for improvement, and that really is around how we develop safety cultures. What are the tools for building a safety culture? And I'll touch on those as well. But I think it's important for us to reflect on that individually. What does it mean? What are our values and attitudes? And we already know that we've got increasing numbers of older people coming into our care. What does that mean for us? How do we value those people that come into our care? What are the challenges that brings up for us? How do we reflect on that in our day-to-day? And how do we reflect in that in our attitudes and our conversations with one another? And how do you support the teams in which you're working as well? Because how we act, our habits and behaviours can influence whether or not we're actually working to provide safe care and providing a safe culture, and also safe care for the people we're caring for. So we need to think about an older person and what comes to mind. And of course, when we talk 65 and over, we're talking from 65 up to over 100 now. I mean, it's many, many years. When these people come into our care, they come with a life's journey and their stories. You've heard Bob's story today, but many of them have had life experiences that you and I would never experience, particularly those coming from cold backgrounds, from overseas, where there's been trauma, where they've been disassociated from their communities, where they've been in refugee camps or wherever, and conflict that we have been very fortunate in Australia never to experience. What does that mean? So they come with a richness of diversity, and it's for us to understand that and how we reflect on that when we're providing care. So I want to talk a little bit. Lucy touched on HACs, hospital-acquired complications in relation to falls. When we were thinking about the work that we're now working and supporting, we looked at hospital-acquired complications, which are the ones that are acquired while people are in hospital. And we looked at falls, pressure injury, delirium, and hospital-acquired infections. And that's when the trigger came to me about how we link these together. It was through a colleague of ours at the CEC who was talking about hospital-acquired complications, UTIs and pneumonia. And I went, well, why have we got so much UTI and pneumonia happening in our care? What's happening here? What is it perhaps that we need to bring together in delivering care to provide safe care for older people? And then we thought about it more. My colleague Marie Connolly has worked on the pressure injury program. And I meant to say Ingrid Hutchinson, my colleague, has worked with me for years on the Falls program and now in the Older Persons Patient Safety. She wants to be here today, but it is an apology. She's not able to be with us, but hopefully she's online. So hi, Ingrid. we then thought, what does this mean for us in terms of our hospital-acquired complications? What is the framework that we can begin to bring these together? So in doing that, we've developed a dashboard from QIDS, which provide the data around delirium, falls, pressure injury, hospital-acquired infection, pneumonia and UTIs. And that we share with those teams that we're beginning to work with in terms of quality improvement, but also share with our clinical governance teams or those that are interested in looking at how this data is affecting them at a ward level as well. So we've developed what we now call a CEC model of care, minimising harm, comprehensive care. And the basis of that, of course, is the Australian Commission on Safety and Quality National Standards. So we've brought together a model for minimising harm. Now, look, none of this is new necessarily, but it's how we bring it together at a ward level. How do we work together as a multidisciplinary team to ensure that these areas of care are being adequately cared for and appropriately managed? So on the left-hand side, you'll see where I sort of started with those being the building blocks, but we feel that these things have to come together on a ward. So we do need to do safety huddles. We need to collaborate and communicate as to which patients we feel today we're concerned about. It's not like in a medical ward where you'll have everyone potentially at risk for a fall. It's those today, those that yesterday were fine, today they've got some behavioural issues. They're not quite as well as they were yesterday. How do we flag that as a safety huddle as the first start? How do we share what we're experiencing? How do we share that then with the team as to what is that plan of care that we need to do for today? Now, we've got across wards in different places where we're running safety huddles at the beginning of every shift. Sometimes they're running them even more quickly than that. If depending on the nature of what's happening on the ward on that day, they will call a huddle so that they can huddle together with team members and begin to discuss what the strategies they need to put in place. Post-fall incident and post-fall huddles, you know about those, I'm sure. When we review serious incidents for falls, and we get them at the CEC, the SAIA reviews of the serious incidents, and might I say we've just done a review of 76 of them over the last few years. And what we find very often is that when and I've been involved in a lot of SAIA reviews myself, we go and ask staff about the incident a few weeks later, well after the event. So what and then staff, staff will reflect. I can remember one staff member said, "I'll never forget because I can't forget that clunk of the head on the floor. It traumatises her as a nurse." She found that very distressing. But others begin to get a bit vague because you're so busy. And I need to acknowledge that as well. When I talk from the CEC, I'm a nurse by training. I have worked clinically, I have worked in aged care, and I've worked across multiple settings, including community. But I know how hard everybody's working now, and particularly through COVID. So I respect that. And I have to acknowledge that to you, that it's not an easy care environment that we're now currently working within. And so when we talk about this is not pie in the sky, but it is around, in our busyness, have we got time to stop and reflect? And have we got time to consider, are we well looking after these areas of care? Excuse me. And in a post-fall huddle, what happened and what can we talk to the patient and or family or carer at that time and really discover what were the issues? What's the plan of care we need to fix now? What can we put in place to make that happen more effectively? Purposeful and intentional rounding. Get lots of feedback about intentional rounding. We've done some quality improvement initiatives across the state in regards to that with certain wards. And I get a lot of people getting quite upset with me saying, it's an insult to my professional practice, Lorraine. We don't want it, we don't need it. And we certainly don't need any more documentation. So I'm not going to be involved in any more forms development or whatever. I'm not talking forms necessarily. But I am talking about how we are regularly checking in on our patients. And especially now with some of them in the new builds, and those of you from Prince of Wales who are going into a new site soon, into single rooms, we've done a lot of work with different other hospitals when they've opened up their single rooms. Sometimes we've noticed the falls go up, and it's a workforce issue and a workflow issue as to how we manage managing patients in single rooms. So one of the ways is how we're going to do regular checks on those patients. But it's not just putting your head around the door and going, oh, hi, are you okay today? Yep, fine, okay. I appreciate you're busy, but it is around. Are they able to mobilise? Have they been turned? Can we sit them out of bed? Can we start early mobilisation? Have they been fed? Are they drinking? Do they need to go to the toilet? Proactive toileting. And we know, and Lucy's shown us, when people fall, most of them, they fall at the bedside or in the bathrooms. When we did Leading Better Value Care a few years ago around initiatives, we could have just run a whole collaborative on toileting. How we manage and provide care for people who require assistance for toileting. How are we proactively managing that? It's a really essential part of care. And it's not necessarily only a nursing responsibility. So when I'm talking about this, it's relative to all of us in terms of providing care across a whole ward, all the teams that are there, and how then we manage to get people up safely and support them to the bathroom. We make sure that they are safe while they're in the bathroom if we can, and then support them back. It's a huge strategy. So I say, I'll come back to that in a moment when we talk about the other aspects of care, when we unpick some of those. Clinical bedside handover. I know in certain spots, and I'm not suggesting this is true for South Eastern Sydney, that handover still happens at a station. We actually are wanting handover to happen at the bedside. And we want the staff that are there, the agency staff or the new grads or whatever, to be well understanding of the care that they're now going to provide the next shift for that patient. And that's the time as young staff members that you speak up at that time at the clinical handover, and you can say, look, I'm a bit worried about Mrs. Brown today. She's just not quite the same. I'm not sure that she's got an early sign for a delirium. Behaves a bit strange. We need to look at hydration, whatever's happening. Pain relief. We often underappreciate pain, particularly for people who are confused or those with dementia. So it's at that handover, at that critical time. But it's also the conversation about how we engage the family if they're sitting there as well. This is not secret squirrel business. What we do to a patient affects families as well, and often they have a lot to contribute in terms of patient care, and particularly in relation to someone who might be confused or with delirium, because they've got them at home full-time, caring for them predominantly. So they're part of the process of caring, and more families want to be involved. So we can have those conversations, engage with them as well, so they're familiar with what we're planning to do in providing care that day. Multidisciplinary bedside rounds, optimal if we can have them. I know it's very difficult, and sometimes it's more able and enabled in rehab where they come together, but in other wards it's possible as well. And so we do support processes where we can engage all parts of the team. And data intelligence. Now, what we mean by data intelligence is we've shown dashboards, we taught up the data, and that all goes up to a high level. I keep going, oh, that's great, really good. We know our falls are bad. So what's the strategy we're going to do around that? And what data has gone back to the ward? Where have we sat with the staff at a staff meeting and said, we've had an incident today, this is what's happened, this is what's going on in our ward? Where are we providing the staff with the feedback around all that stuff that they put into IMS and all that stuff they put into their patient records or whatever as well? How do they get involved in the conversation to help drive improvement? So it's something to be thinking about. Now, just on touching on data intelligence and IMS, it's clunky. We thought when we got the new IMS systems in Plus that we were going to be less clunky, but it didn't work out that way for various reasons. So we have a SME group now, a specialist advisory group, working with our patient safety team at the CEC to try and look at how we can refine some of the data components within that for falls and pressure injury. We've got 2 going. So we hope to work with eHealth to make some minor changes or bigger changes so that the data can be put in fairly quickly, but we get good data out that tells us what's going on, that tells us where the problems might be. And so the aha moments will be at any facility level or at an LHD level, clinical governance, wherever that data goes, we can look at it in a way meaningfully to find out, is that a special cause variation? Was that happening on that day at that time? What was going on in the ward? We don't need to necessarily do a whole pile across LHD just because we've got one special variation in one spot. We actually need to go to that ward and find out what was happening. Was it a staffing issue? What other system issues were contributing at that time? We need to look at the trends, and we need to do that analysis, and we need to go back to our staff at the front line and work with them. And it's not punitive. We're not into being punitive in saying or we might say what's gone wrong here, but we imply in that, how can we work together to drive improvements so this doesn't happen again? What are the issues that you're facing here that we really need to be talking about and be challenging each other with? So the components of the care are fairly obvious there, as you can see, and how that translates in very simple language is all of these little components, and there's more to all of these. And so we are looking at how we actually think about getting people up and mobilising them, how we look at their hydration and nutrition, how we look at cognitive impairment. Now, in the data that we looked at, and I'm sure our dementia care CNCs here will tell us, and Elizabeth, who's working around with, especially with delirium, we underappreciate and under-recognise delirium. It's statewide. It's not only in this local health district, it's other areas as well. And we need to be improving how we alert for the fact anyone at 65 and acute illness is, and particularly the older they get, is at risk of developing a delirium. And sometimes the behaviours or the fact that they're somnolent and not really responding particularly well and sleepy, it could be a delirium. That is a medical emergency. We actually need good clinical management happening straight away. Because if we don't, what we see is escalation of the behaviours. And then we end up with a MET call or a fall and then a MET call because we actually haven't intervened earlier about their hydration and nutrition needs. I mean, I've got instances where a patient may be constipated and it's never been picked up early enough. Oh, lots and lots of stories that we could share in that arena, and people more experienced than me could give you that. And I think they'll be following on from today in terms of that. More would be talking about it. One of the areas that really is relevant for me is that area around patient care fundamentals. And I touched on it when we were talking about toileting. When we talk about pneumonia, hospital-acquired pneumonia, one of the things that is evident from the research, as I understand it, is dental hygiene. Because of the bacteria it can affect, and we get pneumonia as a result. So how well are we supporting oral health? How often are we helping our patients to clean their teeth? How is that part of the personal care when we're providing personal care? And if we're not able to do it because of our roles, then who is the person on the ward at the time with these older people to help them, assist them with their personal care needs? And that's the discussion. And I guess that goes up to a higher level, Dan, and sorry, Jane, around, okay, what's the workforce we require now? Because these are important components. We need to look into it. How we manage a toileting plan, what the environment looks like and how we're supporting that, and how we're assisting them with showering. I'll make a comment on that. You've been recently involved, as Lucy has been the leader on this, is withdrawing red socks. And it's caused across the state a whole pile of huge work because somehow red socks became the fall prevention strategy. They're fine. They won't fall. We'll put the red socks on them. They're given them as a gift when they arrive in hospital. And we've never said it was the fall prevention strategy. It was a strategy for people who did not have adequate footwear. Now, what we found and how we came to a patient safety list about it was through our colleagues working in pressure injury and others who said to us, we're getting people developing pressure injuries on their feet and their toes because they're wearing these socks. Plus, it's an infection control issue. So we then, well, why are they doing that? Are we not taking them off when we go to the bathroom? Have they been to the bathroom? Have they been assisted with some skin care and skin checks? So there are lots of issues. Might I say we've still got a conversation going on now with the pressure injury group around TED stockings. And what does that mean? So wait for that. It's not going to be, that's actually going to be done in a different arena. But just raising the fact that there are strategies that we bring in that might be a good idea at the time, but then they actually have complications later. So when we talk about the showering environment and the personal care needs, the issues are we taking off the TEDs? Are we taking off the red socks if it's appropriate that they be wearing them, and so on? A community nurse even raised the pressure injury problem with socks, with people going home. And they were asking our community teams for more socks when they got home. So it's an interesting area now that people are involved. They can buy them from the pharmacy as well. So the question, if those of you who work in community as a community outreach team, you see someone in the socks, then it's worthwhile asking them how they're managing it and taking them off, and all those questions around that as well. But I get lost. Medication review is really important, polypharmacy particularly, and you will have some discussion later today around polypharmacy and medication. And we do particularly want to focus on, if it's still happening, the reduction in the use of night sedation. It's really important because that makes people sleepy and dopey, and it has a half-life that lasts until the next day. Now, also when I review serious incidents, I never see what medications they're on, of the ones that we say are culprits, and we never see whether or not a question, are they on night sedation? Because they could fall the next morning because they're still dopey. And yet when we look at our data, and I'm sure, Lucy, when you look at your data about the time of day, mostly it's during the day. A lot of the falls happen during the day, and I know it's busy. People are off doing things from 9 o'clock generally, 9 to 11, 12, and then the peak in the afternoon, and then a little bit of a peak at the end of the day, probably because people are getting up and showering and then wandering off to the toilet after breakfast and their cups of tea and so on. So it's something to think about. Safe and early mobilisation. I won't go into detail, but we've done some good work from South Eastern Sydney, who, with Jamie, prior to Lucy coming into the role, and a few others, Daniel Tracy and others, physios and OTs, developed up a guideline for mobilisation and understanding the terminology about supervision, assist, non-assist, all of those things. So we built on that as a statewide strategy, and we've developed a number of resources, and I'll show you some of those later as well. So that's really important around how we understand how to move someone to the side of the bed, how we stand them up, are they safe to walk? And can we assist them to walk as well? And then end-of-life care. This is a really important part of how we have those challenging conversations with patients that may be heading towards the end of their life's journey. And quite often when we see them coming in, the fall might be the precipitating reason for why they arrived at our front door. But it could be because they're really not well and they are at that stage of that final phase of their life, whatever that means. And how do we start having those conversations around what will their end-of-life decision and care planning would be? And we know that so often when we read the journey, sometimes we wonder at what point have those discussions been had. We intervene, but at what time do we stop and talk and discuss with the family and friends about their end-of-life wishes, respecting the fact within some cultures it's a very difficult conversation to be had. But it's a really important part now, and we're all involved in it, particularly with older people, and how we develop the skills to raise those kinds of conversations with our medical staff, our other supporting team members. What matters to me is in the middle. This is a key area for us in terms of how we engage with families and carers. It is an important part of our comprehensive care plan and partnering with patients' families, and Dan, you'd be well and truly on top of this. How do we have those conversations and engage with them and be part of the planning? And how do we sensitively engage and talk with them? When someone comes into our care, they want to be safe. They feel as though that's why they're here, that they're going to be well looked after. And we do. Generally, we do. But they want communication. They want us to show compassion and across the continuum of care, and how we communicate across the continuum of care, and how we do that sensitively and take time to do that if we can, and if we don't, how else we can do it as well, involving others in that conversation. Just before I go on to the resources that we have, I just want to highlight when I started talking about teams and working together. We've got a team that we worked with in one of our hospitals in another LHD who changed their whole way they functioned in a ward. And it was through looking at our model of quality improvement, which I'm going to touch on, asking the questions. And the NUM kept thinking, oh, well, I'll just do this, give them the form and off they'll go and it'll all be right. Well, it didn't. It failed within 5 days, and he he acknowledges that. So through a process of looking at data and doing some further analysis, they've actually built how they work together as a team, how they communicate as a team, how they collaborate, how they function in their huddles, how they identify people at risk, how they communicate that with each other, to the extent that a ward clerk will put a hand up and say, I need a huddle. And the ward clerk will say, I've got 4 admissions today. I don't know where to put them in the ward because you need to help me understand what's going wrong with them, where I can put them effectively. This person would seem to me that they might need to be in one of those closer observation rooms because of where they've come from. So how do we work together? And they work together and they sort it out, and it has changed their whole approach. The other part of the team, apart from our health professionals and so on, are our dietary assistants. We've worked with HealthShare, we've had some conversations with them, how we can support our dietary aides and people and our wards people to be able to deliver safe care, and how we help them to be observing and to raise the conversation when they're concerned about somebody. So we've had a cleaner in one of wards in another LHG who said, you know that stuff you're talking about, delirium and all that, because he heard what was going on. If that patient there today is in trouble, you need to do something there. You know, and you need to go and use that tool you're talking about down there. So how important, they may not have the full knowledge that we all have necessarily, but they have the eyes and they're observing. And patients talk to those staff. They share stories with them. They observe what's going on. So they're a vital part of the team. So how do we support them and encourage them to be a really valuable member of the team? So this is our Older Persons Patient Safety Program website. It's on the CEC website, and you find it under Keep Patients Safe. And then if you put down that, you get Older Persons Patient Safety Program. So everything that I've talked about today and the model and so on is all there for you to look at. Now we're evolving, we're learning, and we're open to improvement. So if any of you have got some suggestions for us as to what we can do here to improve the information that we've got up, we'd be gladly welcoming that from you. We're also looking at quality improvement and how do you go about running a quality improvement initiative on your ward. So we're working with our CEC Quality Improvement and our Academy in regards to that. But we've developed a toolkit, which is how you get started, and that is also on our website. How to get started? What are the tools you need? What is it about quality improvement? How do you do a data collection? How do you do your little PDSA cycles and so on? Really important, and we get a bit of kickback. We're doing work across the state with different LHDs, and they don't like the idea of data, and they go, oh, PDSA cycle, do we really have to write that down? And we want to start doing the whole ward, and we go, no, slow it down, just start with 1 patient, then go to 3, and then go and then build on that. So we want the successes. Let's learn, let's talk together. Did that work? No, let's try it out and let's start on something else. So that's the process, and I'm being very simplistic, but that's available to those people who want to learn more about driving quality improvement initiatives. It's been interesting when we actually had the conversation at a ward level as to what projects might evolve, and a great variety of things that they begin to focus on. We've got one now that's aware that perhaps some dietary needs aren't being dietary needs for patients at night, particularly those people who are confused. We need to make available so that they can be fed during the night as well, or watered with some hydration. So they're looking at how they can effectively have that more available for patients during the night, as an example. There are lots more. So this is the CEC Safety and Quality Essentials Pathway. Some of you will probably be already involved in this and part of the training and so on. There's the foundational level, intermediate level, and then the ADAPT level. And that's what we're hoping is within each LHD, we will have people at the ADAPT level who will be supporting programs across the state. We are a small team, Ingrid, Marie and I, and so therefore we can't drive all of these quality improvements initiatives across the state. But we want LHDs to develop that capability to be able to do that. If you're interested in how that's worked across some LHDs, at our Falls Forum last year in May, we had a number of different examples of different teams getting up and talking about what they've done. And some of these would never have thought they'd be up presenting to anybody. So it's fabulous to see how excited they got when they began to see improvements in their care and the collaboration as well. So if you're keen, I'd ask you to go there. We've got another Falls Forum. I'll come back to that one. Oh, resources we've got. I'm just conscious of the time. But we've got another Falls Forum coming up on the 26th of May, was it? Yeah, Friday. I get the days mixed up a bit there at the Wesley Centre. So we're actually we're doing that virtually and face-to-face. So we can have about 300 people in the auditorium. Usually we have a full auditorium as well. So that program is being finalised now, but we haven't call out for abstracts. So if you've got any good little projects that you're doing and want to showcase that, make sure you go online and get your abstract in now so that we can actually prioritise that for the afternoon session, whatever that is. So just going back to this one, the CEC funds through contract to Neuroscience Research Australia under Professor Stephen Lord, the New South Wales Fall Prevention and Healthy Ageing Network. And this is their vision about fall prevention and healthy ageing. And I thought I'd just pop that in because we have a bigger focus there around outward-facing activities from building community capacity. So the CEC at this stage, we're involved heavily in what we do in supporting care in hospitals. We also need how we're going to build the capacity in care within our other environments. These other slides that I had there, you can all see, these are just examples of resources and also how we're working to build capability within our LHDs around driving improvement work. So I think I've spoken enough. There's a huge area in terms when we're talking about falls and we can't cover it at all at any one time. But please don't hesitate. If not today, if you'd like to make contact, please do. We're very welcome to supporting you in the work you do, and I wish you well, because you are our leaders. You are the people that we rely on in our health services to drive the change and to be the ones that are going to be collaborating and supporting to improve safe care for older people. So thank you.
Thank you, Lorraine. Are there any questions in the room? Lorraine? Just acknowledging too that Ingrid did reach out online and confirm that she's online. So, yeah. Are there any questions? Are there any questions online? Not at this moment? Okay. Thank you. You must have been very comprehensive. Very. Exactly. Thank you very much.
Thank you, Jane. Well, we're almost at morning tea. We've had a jam-packed morning full of some really exciting talks. Lovely to hear from Bob this morning and have the patient experience threaded through the work that we do. So, some of you may not know, I've just written a book on stairs. Thank you. It is a step-by-step guide. Aha, I have not, just to confirm. But I couldn't resist the urge. So if anyone has any good falls jokes, throw them in the chat or the Slido. So I'll invite our next presenter up in a moment, Libby Powell. And Libby is our Manager for Healthy People, Healthy Places from our Health Promotion Service. And Libby has a very extensive bio covering her very extensive career. So I'm going to read every second word just so I can get through the whole thing. So Libby is people, places with equity and service. Eastern Local District has background. I won't do the whole thing. But Libby is a wonderful member of our team and has a background in sports science and was drawn to the field of health promotion over 25 years ago. Starting her career in Manchester in England, Libby coordinated community-based cardiac rehab and GP exercise referral programs. Coming to Australia in 2005, Libby transferred her experience in adult health promotion to address the rising public health concern of childhood overweight and obesity, and contributed to the implementation and evaluation of a childhood obesity prevention program with the Australian Sports Commission before commencing as a health promotion officer with South Eastern Sydney Local Health District in 2007. Round of applause for that. In her current role, Libby has contributed to various local and state research projects and manages a team of health promotion officers and the development and implementation of several physical health programs and health promotion initiatives to improve health outcomes for adults and older people. Libby finds satisfaction in supporting new and future practitioners further develop their insight and understanding in health promotion and preventative health, and to nurture their passion and areas of interest in this rewarding field of work. So Libby's interesting fun fact is that her grandfather worked with Paul McCartney's dad when they were working in the Manchester cotton mills. When offered a complete signed copy of the Beatles' first music album, her grandfather declined, saying that he didn't really like the music and to give it to someone else. Big mistake, Grandpa. Imagine what the album would auction for these days. So welcome, Libby.
Okay, good morning, everybody. Before I begin my presentation, I would like to acknowledge the custodians on whose land we are meeting today and pay my respects to elders past, present and emerging, and any Aboriginal people joining us at the forum today. Thank you, Dan, for that introduction. I must produce the bio next time. Okay, so a little bit about our service. So in August 2022, the South Eastern Sydney Local Health District Priority Populations Unit and the Health Promotion Service joined together as a single service. And as of the 1st of January 23, we've adopted the new name Health Equity, Promotion and Prevention Service. This change in service name reflects our enhanced focus on equity and prevention with a dual focus to firstly address the health needs of people experiencing disadvantage, and secondly, to enhance the knowledge, skills and environments that support healthy living and the prevention of chronic disease. Our prevention priorities include healthy ageing and falls prevention, cancer prevention and screening, obesity and diabetes, and Sorry, Dan, how do I come down the notes? Sorry about that. Oh, I have to do dual. Oh, okay. Tricky. Smoking, vaping, and shisha smoking. Our equity priorities include Aboriginal communities, carers, culturally and linguistically diverse communities, LGBTQI+ communities, people experiencing homelessness, people living in social housing and low socioeconomic communities, women experiencing disadvantage, and vulnerable young people. So that's our newly integrated service. This morning I'm going to present some information about 3 New South Wales health prevention programs that contribute to better health outcomes for adults and older people. I'm going to share some information about local community-based exercise programs that promote falls prevention and healthy aging and falls prevention resources, and how you can get hold of these resources to support your patients and health messaging to those patients, and a couple of quality improvement initiatives related to falls prevention that my team are co-producing and implementing with both internal and external partners. Okay, so it really fills me with dismay that on average, Australians live almost 11 years in poor health, or around 13% of their life. Falls and injuries from a fall by older people place huge burdens, as we've already heard today, on individuals, families, and the wider community. In our district, 1 in 3 people over 65 years fall each year, and 1 in 2 for those over the age of 80 years. Consequences of falls include serious injury, hospitalisation, further fear of falling, and reduced quality of life. Excess body weight, or overweight and obesity as we often refer, is one of the main public health problems in Australia and globally. The risk of developing chronic disorders increases with increasing levels of excess weight, including cancer, cardiovascular disease, and the prevalence of high blood glucose or diabetes. Diabetes increases with age and socioeconomic disadvantage and is more prevalent among Aboriginal people compared with non-Aboriginal people in New South Wales. The New South Wales Population Health Survey 2020 to 21 reports that 52.5% of adults were overweight or obese, an increase from 47.1% 10 years earlier. And between 2009 and 2019, diabetes increased from 6.7 to 9.7%. And further, in 2020 to 21 in the census data, in terms of our residents, only 41.8%, or around 4 in 10 people, aged 65 or over, met the physical activity guidelines of at least 30 minutes of physical activity each day, which means 58.2% were not getting enough physical activity. New South Wales Health is committed to providing information, programs and services to help people make healthier lifestyle choices. There's a range of free programs that will address modifiable risk factors for both chronic disease and to reduce the risk of falls for older people and improve the health and quality of life of your patients. Today I'll present 3 of those prevention programs. The first of these is the Stepping On program. Stepping On is a free evidence-based falls prevention program. The original randomised controlled trial reported 31% reduction in falls by those actually participating in the study. The program focuses on improving balance and leg strength to reduce participants' risk of falling and to promote and maintain their independence. Right. The program is for adults aged 65 years and over, and 45 years and over for people from an Aboriginal or Torres Strait Islander background. Other eligibility criteria include someone that's had a fall or has a fear of falling, people that live independently in the community, and they can also walk safely at home without a walking aid. Each program runs for 7 weeks, where participants attend a 2-hour session each week of the program. And as well as performing the evidence-based exercises each week, different expert speakers attend and provide information related to falls risk factors. The presentation topics include road safety, eye care, diet, home hazards, and medication. The programs that we coordinate in South Eastern Sydney are available both in English and in language. Providing in-language programs improves access by people from a non-English speaking background to both the program and to other healthy ageing support services. We work to recruit people to programs located near to where they live, and we hire venues that we hope are familiar to the participants, for reasons that they may visit a community hall to go to a coffee morning, or a church hall, a library, and we feel that that's a really important aspect of tailoring the local program. Pleased to report that all of our programs are now back face-to-face following the virtual program delivery mode when we were suspended through COVID restrictions. For those individuals that don't meet eligibility criteria, it's worth maybe looking at alternative options like the IREAP, which is the Integrated Rehabilitation and Enablement Program. So I'm aware that this program is run from War Memorial. I think, I don't know, Lucy, is it from just War Memorial? Yeah, much higher, much lower ratio from the participant to the facilitator. And these programs are really targeting those at risk of frailty, Parkinson's disease, and other neurodegenerative conditions. Okay, clinicians, be aware, we've gone digital. At the end of last year, Stepping On registrations moved to an online portal, and I'm aware that some clinicians have already made that switch, but for those that are yet to go there, please try and have a go and reach out if you need any support to navigate around this portal. The information required is exactly the same as the paper referrals, so hopefully no surprises when you come to it. You will need the patient's GP contact details and their emergency contact details when registering. The second option is self-referral, but to be honest, I don't really like to promote this option as we find that people either don't have laptops or computers at home, or they don't necessarily feel confident to register to the program in this way, which may result in a no registration, which is definitely not what we want to happen. And the third registration option is a direct line, a new centralised phone line, which you can see there. The telephone number can also be found on the Active and Healthy website, which, again, if you haven't already visited this website, I can't encourage you enough to do so. This is where this is sort of the main portal of all the programs. The person at the end of the phone will register the patient, but again, they will need all of those details to complete the registration. And once complete, a member of my team will send out a letter to let them know the registration's been received and that someone will contact them about a program in their area. The second free prevention program is Healthy and Active for Life Online, or HAL Online. Eligible patients should be guided to register via the Active and Healthy website. And just to note that HAL Online brochures are available from our team to give to your patients. I think there's some on the resource table outside, and you can also jot down your name and contact details if you want some of those for your service. It's a self-paced, healthy lifestyle program for people over 60 years and over 45 years for Aboriginal or Torres Strait Islander people. It's a 10-week program with 2 exercise circuits a week, each with varying degrees of difficulty. So basically, the participant is safely challenged as they progress through the program. A weekly phone coach calls for each participant and is available for personalised support and questions relevant to their needs. Participants receive resources free of charge, a manual and an exercise log. The manual is a printed version of actually the online modules, and the exercise log allows those participants to measure their improvement on a daily basis and then talk to their phone coach about how they're getting on. Participants should have a functioning knowledge of the online environment and an internet connection to be able to access this program. The third program is the Get Healthy Information Service, a free telephone-based coaching service to assist adults reach their health goals in relation to healthy eating, physical activity, achieving or maintaining a healthy weight, and/or reduction of alcohol consumption. The service encourages and supports self-management by providing individualised information, advice, and support. An action plan is written up with the participant, and methods for maintaining motivation and addressing barriers to lifestyle changes are also covered. The phone coaches are university qualified health professionals, including dietitians and exercise physiologists. Health coaches are available 5 days a week from 8 in the morning till 8 at night, and coaching times are organised to suit individual participants. Participants get 10 phone calls over the 6-month period with the same coach. And coaching calls take around 15 minutes. And they're usually closer together in the first 3 months, and then they're spaced slightly further apart at the back end program. They get an information booklet and journal, and they can personally choose and record their goals and track progress. A medical screening questionnaire is included in the first call, and participants will be referred to their GP for clearance if required before continuing. For participants who don't feel confident speaking in English, interpreters are available in a wide range of languages. For individuals that speak Chinese, there's now Chinese-speaking bilingual health coaches, and the resources have been translated. All participants can actually re-enroll for a further 6-month program and continue to work on new goals, new health goals. So in addition to the New South Wales prevention programs, there's various community-based exercise programs that promote healthy ageing and falls prevention in the community. Supporting older people to register to attend exercise classes with a strong balance and strength component is key to promoting falls prevention. We find that people graduating from our programs be nervous about starting a new exercise group outside of the clinical setting and the health prevention programs that we deliver in the community. We all have a part to play in promoting these pathways of care and supporting patients to register and to also go on and participate in the appropriate programs following whether it be graduation from the Stepping On program or a rehab clinic or a point of discharge following a hospital stay. So on the screen, you can see a number of programs that are available locally. First two are actually ours. The AIM program is coordinated by the community health team at Prince of Wales, and they're delivered across the eastern suburbs area of our district. Classes are delivered by qualified fitness instructors from community venues as they're across that area. These classes are suitable for most fitness levels and aim to improve balance, strength, flexibility, endurance, all in a fun and supportive environment. We then have the Strengthening for Over 60s program that operates across the St George and Sutherland areas of our district. Today we've got Camilla Hofort here at the back, giving us a wave, and she's at the resource table outside. Camilla is the program coordinator for the Strengthening for Over 60s program. We've also got the Living Longer, Living Stronger program, which is a progressive training program designed to improve strength, balance, coordination and endurance. And again, Camilla, with her other hat on, is the program coordinator as well, and there's resources outside at the table. Share offer a range of classes across the southern part of our district and also part of Sydney LHD. So if you do have any patients that reside closer to the city, then the share classes may be appropriate for them. The kind of classes that they deliver include Tai Chi and some classes with strength and balance components. And then we've also heard from Tobi this morning about local councils and the partnerships with our local councils. We have long-standing partnerships with a number of our councils, and each of those councils has their own concessionary cards and programs for people over 50. So to find out more, you can either jump on the website and find out what's going on, or encourage and support your patients to visit those facilities and meet the staff themselves. Next, I'd like to share 3 quality improvement initiatives that our service are leading to enhance healthy ageing and falls prevention messaging and service provision. So in terms of upskilling our community fitness leaders, you know, it's hard to keep track of what's going on in the community and what classes to promote and to you know, to which services. So we're currently collaborating with our colleagues over in Sydney LHD, and Sally Castell, who's well known in terms of her experience as a practitioner and now as a registered training provider. to co-design a hybrid training course for fitness leaders. What this will provide is some level of insurance or assurance rather that there's a dose of balance and strength within classes that we feel happy with, and that we see a pathway of care from some of our existing programs. We hope to have that training up and running by April, May this year. Secondly, we're collaborating with Lucy, and I know, Lucy, you've mentioned this resource and these exercises, and also our allied health leads. I know Daniel Tracy's up the back there. I'm not quite sure who else is here today, but thank you for your direction and guidance in terms of refreshing this resource that we can see on the closest to me here. We've had some direction on the content to keep it relevant. And the next phase now is to consult consumers to ensure the information and visuals, not those visuals, are clear and appropriate for our target populations. We plan to have the refresh resource released at by the end of June this year. So watch out, because we'd love to see it being handed out at discharge and end of clinics. And our most recent initiative is a series of healthy aging videos and social media assets. I'd like to think that many of you in the room have received the links to these videos. We did actually launch them on the 2nd of Feb to coincide with Seniors Week. They have been uploaded to the SESLHD YouTube account and shared widely both internally and with our external community-based partners. The key themes that have been captured in the videos relate to healthy eating, active living, strength and balance falls prevention, and staying connected, which was coming out hopefully the other end of COVID, and the isolation again that Toby alluded to, and the deconditioning of people during that period. We're very proud of this resource and where it's come from. The fact that it has been produced in collaboration with consumers and with service providers. Certainly if we develop these resources behind closed doors, they wouldn't look like this. And we're glad that they don't look like something that we would produce. So if you haven't seen it, I don't think I have time today, but Dan's promised me he'll play one of them at least later. We will be promoting the Strength and Balance video as part of the April Falls campaign. The way in which that some of these videos, just to sort of give you a taste of how they've been used, is I know our colleagues in the Oral Health Service, the Bogwood Clinic, have uploaded the videos to their TV loops in waiting rooms. It would be absolutely fabulous if you could follow suit and do that and have them running in your own clinic areas. At bedsides, through laptops or any computer systems that you have on the wards. And any e-newsletters spread across professional networks as well as internally as well. So we know from the data and speaking to our colleagues across the clinical services and community organisations that current healthy ageing and falls prevention interventions are not reaching those hurry up, distract by 5 minutes, and not reaching or don't meet the needs of people experience the greatest disadvantage. This means that a proportion of patients are not receiving the evidence-based care, and we know we can do better. We believe it's time to review and refresh some interventions to meet the needs of our communities, and we need to provide more of what does work and stop what isn't being so effective. I'm really pleased to be here today because I believe that today's forum provides an opportunity to reflect on current practice, discuss gaps in service provision and opportunities for improvement, and also to identify areas for further support. Which leads me nicely to my final slide, where you can see the kind of support that the Health Equity, Promotion and Prevention Service can offer to staff and to patients. From training and in-services for staff, resources for staff and patients, including translated resources, supporting referral to prevention programs, navigating the Stepping On portal, supporting with QI projects and any other physical health promotion initiatives within the scope of our prevention and equity priorities. I also ask you to consider any opportunities for health promotion and prevention within your everyday service. We're here to support you to implement strategies, no matter how wild they may seem today, or as you go back to your teams. We ask you to please reach out. Here are my contacts are at the bottom of this slide, and then you've also got some key contacts for general inquiries and registration. So thank you for your time today.
Thank you. Really wonderful overview of the programs. Yeah, gone flat. Really great overview of the programs that you lead across the LHD to support our patients across the spectrum of their experience and journey. We did have someone online ask us a question to pose to you. Their mother suffers from osteoarthritis in both knees and wonders what programs are available, or can people that haven't had a fall be referred to some of these programs?
Yeah, I would go back to going to the GP in the first instance and establishing some history in terms of what would be appropriate. Stepping On wouldn't necessarily, say there's eligibility criteria, but there are other programs out there like the Living Longer, Living Stronger. I think it also depends where she resides. So more than happy to take any inquiries like that. My email's there, but as I say, without the doctor's referral, it's quite difficult to say. Thank you.
Thank you so much, Libby. We will play those videos throughout the day, so you're able to see the wonderful resources that have been developed by the team. So I might hand over to Jane.
Thank you, Dan. So I get the joy of telling everyone it's now morning tea time. If you'd like to come back and join us at 11:05, so you have a few minutes, and if you need to dash to a cafe locally to get a real coffee, please feel free to do so. So thank you very much, and thank you for a great morning session. Thank you.